Uh, there we go. So I'd like to welcome everybody today to our Center for Suicide Prevention and Recovery Spotlight Talk. Today, our speaker is Dr. Elizabeth McCauley, one of the core faculty in CSPAR. Elizabeth is a developmental and clinical psychologist and professor in the Department of Psychiatry and Behavioral Sciences here at the University of Washington. She's also Associate Director of Child Psychiatry at UW and Seattle Children's Hospital. Dr. McCauley's clinical and research work focuses on the depression and suicidality in youth, as well as school-based mental health services delivery. And she was one of my first and best supervisors when I came to internship, back in the age of dinosaurs. Uh, Elizabeth has developed or tested prevention and intervention strategies in clinical settings, school settings, primary care settings. She's been the principal investigator or co-investigator on a large series of randomized controlled trials evaluating the efficacy and effectiveness of interventions to reduce depression and suicidality in youth, including a major trial of DBT for adolescents. In addition to her clinical trials, Dr. McCauley has been integral to the development of multiple clinical programs at Seattle Children's, including the Crisis Care Clinic, an outpatient crisis stabilization intervention that's been a really successful alternative to inpatient psychiatric treatment for teens who are experiencing suicidal thoughts or behaviors. And she's got a co-investigator on a large trial that, as part of one of our other center trials, to evaluate it in an optimization study. And specifically to her presentation today, Dr. McCauley was co-PI of the Developmental Pathways Project. This was a long-term study of social and emotional health and development of 520 ethnically diverse participants, followed over 9 waves of data collection from age 12 to age 31. And I really want to say thank you so much, Elizabeth, to presenting today, and I'll give it over to you.
Okay. So I'd like to keep this as let me know if you can't hear me. I seem to have lost some of my control, so I don't know how to correct that if you can't, but I would hope that we could make this, it's a small group, very interactive. And let me start by saying why first of all, I'm talking about trajectories, I can't say the word, of suicidal ideation from adolescence into early adulthood. And we'll talk a little bit about the definition of early adulthood. This particular data set I'm going to talk about has focused on the interplay of alcohol use, negative events, and perceived support as they affect that trajectory. But let me go back to the bottom here and say I'm representing the Scooty project team. And the reason I'm presenting the Scooty material in this forum is because this is a small family foundation grant that we got, which we actually put in as one of the first funded CSPAR projects way back when. And so it has its home in CSPAR. Molly Adrian, who I think most of you know, has played a central role in this work. Sarah Danzo, who some of you may know, and Andrew Kepti have been key on the data analysis and presentation for much of the data I'm going to present today. So I take minor credit other than securing the funds. I've been working on all these projects, but it's those guys get really a lot of the credit, all of the credit. So I'm going to put up, this is a local family that established this foundation, which is a small foundation. And I think they've kind of waxed and waned in what they're hoping to do. But they first were, and I think this is something that is not uncommon to the field in which we work around suicidality, that families are devastated when this happens to one of their family members, unsure about how to respond or what to do, how to kind of manage their own feelings and thoughts. And so this is one of the steps that they took. And for this family, and I don't know a lot of personal data about this young man, but I feel like I can share kind of the general picture. Um, this was an uh, death by suicide of a 22-year-old young man who was about to graduate from college, did not have a long-standing history of complex mental health problems. And so this was really something that took the family totally by surprise. So they were interested in trying to figure out what factors might have contributed. In this case, their focus was on attention to kind of individual characteristics because they didn't really they hadn't identified, he did not have a long-standing history of depression and suicidality or problems that could have maybe led them to be less surprised by this. So what we proposed to them when we were first approached by the family, we proposed to use and build on the data set from the Developmental Pathways Project, which is what Kate just referred to, this longitudinal study that was run, that Ann Vanderstoep and I were co-PIs on. And the Developmental Pathways study was really a study to look at. We had a complex cohort of 521 kids recruited in sixth grade, which was really interesting. And we chose kids who scored elevated on a self-report of depression, are elevated on a self-report of behavioral problems, are elevated on both, plus a control group. And it was recruited from Seattle Public Schools. It is a very ethnically and socioeconomically diverse group, which we are very pleased about. And our initial goals were to try to understand the development of co-occurring depression and oppositional defiant disorder or conduct disorder over time. For these purposes, what we really are going to focus on, because we had data on suicidal ideation and suicidal behaviors from 11, 12 to 30, 31 years of age. So that's what we are going to talk about today. And the first thing I want to report is a paper that a set of analyses that Molly really led, which was kind of our phase 1 work, which was using the existing DPP data set to look at transitions in suicide risk from early adolescence into early adulthood. So these were kids who started out, as we have said, at 11 or 12 with 8 assessments, 5 in middle school. They were ages, at the time of their assessments, they were ages 18 that we're going to talk about here. They were started out as 11, 12, then 15, 18, and 22. The assessments consisted of the DISC, which is a standardized diagnostic interview that's computerized and can be, we use trained interviewers, but they're not necessarily trained clinicians. So it's not necessarily, they're not making a clinical determination. So it's very structured. Lots of review of substance use, social, school, and family factors. And in this study, we did a latent class analysis and looked which found a 4-class model, not to your surprise. I think we see this a lot in latent class analyses. You get 4 factors. And 76% were low risk. And obviously, good news, that was the largest population. They denied throughout each of the evaluations, and we had very good retention, a little bit of off and on with retention, but very good retention over time. They denied passive or active suicidal ideation at every evaluation time. So the bulk of the kids were, good news, without heightened suicidality. And then a smaller percentage were kids who we described as passive ideators with early attempts, or desisters, because they had occasional passive ideation, but it kind of came, it wasn't at every evaluation, and it varied over time. And then we had 14.2% of the population who had occasional passive and death ideations, as well as suicide attempts at early adulthood. So these are young people who kind of escalated over the course of the developmental time that we worked with them. And then we had again a very small number, but we had what you would anticipate, I think. 3.5% had suicidal thoughts and behaviors, including suicide attempts, that were pretty chronic. That doesn't mean every single evaluation, because we did a lot of evaluations, but a pretty significant persistence in suicidality over time. The low and the high risk groups, again, not a surprising finding, had very stable membership over time. So those kids stuck that way. We kind of defined that for the low group. With the high risk group, we could have seen a lot of variation over time and did not. The other groups were very unstable, moving back and forth, up and down, and that's consistent with the fact that they had occasional passive and death ideation, not every single evaluation. And I think that maybe the hope from our funders was we would find some unique predictor for these kids, but what we really found in this sample is that trajectory was predicted by not surprising variables, early indicators of self-worth, poor self-worth, obviously, and difficulty with family issues and family involvement. I think that Kate referred to our crisis care clinic, and we just recently have begun to look at kind of what are the most common problems that kids report, and they are very predictable. And we had the opportunity to have Guy Diamond do a grand rounds with us, and he reported in his sample that family issues were the most salient and consistently reported kind of trigger our issue in kids' lives, which has led to his the development of his intervention, which is very attachment focused. But I would say from and we've seen over 300, probably close to 400 adolescents, 11 to 18, in our crisis care clinic. And I would say the three most common things they report are really issues around their sense of self-worth. And in the suicidal context, a lot of issue about feeling like they're a burden to their family, to their friends. Family issues are, it's hard to say what's tops, and we will try to look at that data and see what's tops, but so I'm going to say them all on the same level. So self-worth, family issues, and peer and school concerns, obviously all intermingling pretty intensely. So that was kind of the early study that we did using our existing data. And then we began to look at transitions in suicide risk from early adolescence through emerging adulthood. And it was kind of a nice time to do a little bit of a dive into the more recent research on what's called emerging adulthood, which may include some of you, and it goes from 18 to 29. So it's a long period of time. It's a period of instability. Changes in residence, work, and social relationships are pretty common, expected maybe even in that period of life. But recent economic and societal conditions, including COVID-19, have given rise to challenges to economic and psychological autonomy. So young people are, I feel like over the course of our sample, there was the oldest group were probably affected a little bit by are more centrally by economic turndowns that made it hard for them to emancipate at the same pace as maybe an earlier generation might have, more dependent on family living at home, that kind of thing. And then COVID hit, and that kind of brought a lot of people back home in that initial wave when people were losing their jobs and et cetera, and had to kind of regroup, and families rejoined each other in order to make it through that period of time. So it has been identified as a super challenging developmental period that's associated with risk for new mental health challenges, including substance use and misuse. And our goal was to look at, examine longitudinal pathways between alcohol use and suicidal ideation across our original DPP sample through this period of emerging adulthood with attention to social support and negative events. So I don't know that I've put a slide in on this, but I would say that what we ended up doing was doing another survey. So we collected another round of data. We reached out to our DPP sample to collect another round of data. So this is a little bit of a different perspective, and the data reflects a little bit of a different sample. We went to a selected sample in part because the funds that we had were not extensive, and we wanted to make the most out of the money that we had. And the second piece is that the donors were interested in what kind of happened after age 22, since their loss was in a young man age 22. So we have our last DPP evaluation had been 21, 22. So we collected a sample of folks who are now in their late 20s. Actually, probably we collected our sample in waves, so it's the way the age ranges can go from 28 to 30, 31 in this sample. The first thing we did was we selected 75 participants who were recruited on the based on their history of past suicidal thoughts and behaviors. We used items from the DISC, including suicidal ideation, suicidal plan, past year suicide attempt, lifetime suicide attempt. So we were trying to identify a subset of our population, of our sample, who are already at high risk in terms of suicidality. And then we use propensity scoring to match the participants by age, sex, ethnicity, and race. We ended up with 136 participants, as opposed to, we were aiming for 150. We ended up with 136 because we would have had to broaden our targeted base, our first 75 participants. We would have had to draw on some, let's say, less extreme indicators of suicide risk to get enough young adults to match. So we decided to stick with our first definition of who was an at-risk person, and we were able to match. So we had an even split in our sample, but 136 total. We used data from the last 4 assessments. As I said, the mean participants were about 30 at the time of this assessment, but we used data from age 15 evaluation, which would be about their first year of high school. Age 18 was their senior year of high school. Age 22, 21, 22 was late college if they were college students, are early work years, and then the 30-year time frame. The measures that we used were suicidal ideation. This is for the 15 to 22 section from the moods and feelings questionnaire. And then at age 30, because we collected another set of survey questions, suicidal ideation was assessed using 3 items from the interview, from the CDRS, CSSRS, and then the participants were asked since the last interview at age 22, have you wished you were dead or wish you could go to sleep and not wake up? Have you actually had any thoughts of killing yourself? And have you been thinking about how you might do this? So we used those kind of questions to identify folks in this new sample. Measures for alcohol use were the customary drinking and drug record and alcohol use disorders identification test, the audit. For social support, we looked at the multidimensional scale of perceived social support. And for life events, we had been using throughout this study the life events checklist, and we were able to continue to use that measure as we moved into the adult last evaluation. For the analysis, we used a cross-leg panel model, was used to assess associations between alcohol use, negative life events, and social support, and suicidal ideation from age 15 to 30. Our goal, of course, and I don't think I've stated it in the slide, was to try to figure out were there factors, patterns we could identify that would allow us to inform or shape more effective earlier interventions and preventive strategies. And I'm going to stop here for a minute to see if anybody has any questions or issues they'd like to bring up. I have a feeling my talk will be brief, so we can chat if you have questions. And then I think it looks like no, I'm not seeing any questions, but I can't see my chat, so I have to give you my context. I'm in my grandson's bedroom, hiding away on a little tiny computer, so I'm not, for some reason, able to see. So here's what we found, and it was kind of surprising to us because our assumption was that alcohol use would be a major risk factor for suicidality, and they would kind of go hand in hand. We found no significant direct paths between alcohol use and suicidal ideation. But we did find some other direct pathways. So alcohol use at age 18, I'm going to move you guys a little bit out of the way. At age 18, led to increased exposure to negative life events at age 22. So this kind of cluster of factors were interacting, not in necessarily simple ways, but in more subtle ways. Age 18 social support was associated with reduced exposure to negative life events at age 22. Again, I think not a surprising factor. And age 22 social support was related to reduced suicidal ideation at age 30. Age 22, I'm sorry, I've flipped off a thing. Alcohol use was related to, no, negative events was related to increased suicidal ideation at age 30. So it felt like alcohol use was really an interplay, if you will, with negative life events and social support, that we had this kind of dance going on between how these factors were relating to each other. And we found some significant indirect pathways that we thought were particularly important and of interest. And it just reinforces this whole notion. So we found a significant indirect path from alcohol use at age 18 to increased suicidal ideation at 30 via increased exposure to negative life events at age 22. My guess is that's not at all a surprising outcome or finding to you, but it does kind of give some sense of what the story is here. That if we're those kids who are using, those young people who are using more alcohol at 18, likely puts them into a situation where they may have more negative life events. And in that kind of more muted or more complex pathway, it seems to be associated with increased suicidal ideation. And then the second indirect effect we found was a negative indirect effect of social support at age 18 on suicidal ideation at age 30 through negative life events at age 22. So basically, increased social support at 18 was associated with exposure to fewer negative life events at age 20, which was subsequently associated with less suicidal ideation at 30. So again, not as surprising, but a more complex dance. And I think we found it a pretty interesting dance to kind of understand what was going on with our participants. And this just shows you the pathways in a figure. So the cross-leg panel model with significance. So again, alcohol use at 15, not associated with 18. 18 was associated with 22, and there was some association with alcohol use as we move on to 30. But not so much with suicidal ideation. Suicidal ideation didn't really come into that except by this indirect pathway. So I'm just walking you through again, age 18, alcohol use associated with more life events, more negative life events, and then that pathway down to suicidal ideation at 30. Social support at 18 was associated with fewer negative life events at 22, and again, kind of leading to reduced suicidal ideation at age 30. And there's a pathway, but not significant, between negative life events and suicidal ideation at 30.
So, Elizabeth, could I just ask a question about that? So
Absolutely.
ideation did not connect itself across the, whether you had ideation at each time point was dependent, it wasn't dependent on whether you had it before. So that
That's
kind of
right.
speaks to I think that's just also really interesting that that's not as opposed to life events and social support, which seems very what happens early on kind of persists.
Yeah, we were expecting suicidal ideation to have more consistency, and I do have a couple of thoughts or comments that our data raised for us that I think we could all talk about. And some of the challenges in doing this kind of research and some of the challenges in doing longitudinal studies that I think are worth considering. But yeah, that was a big surprise to us.
Mhm.
But maybe shouldn't have been from the data I presented it first off. We had a lot of variability except in a small group of people who had pretty consistent either no ideation or a really small group of people who had very consistent ideation.
Right.
And we have not taken a look to see if the people that we were able to recruit for this subsample, and that's something that we could look at, were they represented in that 3% of folks in the earlier phase of the study who had pretty consistent suicidal ideation over time. Still, it's a small number of folks. So the other thing that we were interested in and haven't done such fancy analyses for, we'll be interested in your thoughts about, is this was a finding that we definitely did not expect, is that the percentage of our participants, now remember, this is a subset of people, but the percentage of that subset of people who had reported suicidal ideation at age 15 was pretty small. 15 of those folks did. At 18, it was a little higher, so about 35% of this subsample, and that's across both groups. So we're not, at this point, we're not differentiating, and we can, but we haven't yet. At age 22, it kind of goes down again. And then at age 30, we get the highest number that we got in the entire sample so far of 56 people, 40, almost 41% at age 30, indicating that they had experienced suicidal ideation in the last year or in a recent time period. So we don't know what to make of it. It's surprising to us. And it is not doesn't stand out as dramatically in terms of suicide attempts. We didn't have a lot of people who had made suicide attempts, but even at age 30, we had 7 people who reported that they had made a suicide attempt, and that would be since age 22. So that's going back a pretty long period of time for some of these people. So what's going on with this age 30 cluster? Who are they? We don't know much about them yet. We will do some more exploring, and I'd love your thoughts about what to explore. But here are some of the possible risk factors. In terms of report of suicide ideation, the report at 18 seemed much more significant than the report at 15 or the report at 22. You just saw those numbers, just more people reported suicidal ideation at 18 to a point of transition, perhaps. But then 22 could have again been another point of transition. 48% of these people did report a lifetime suicide attempt. So that, again, that is a pretty high number. So they are a selectively higher risk certainly than our overall sample. 29% of them identified as bisexual. Otherwise, we had a pretty heterogeneous sample in terms of gender and sexual identity, and this is the only, everything else was not very distinguishing between these folks and the rest of the sample, but we had 29% who identified as bisexual. And those of you that know this literature do know that bisexuality is associated with greater, has been associated in other work with greater mental health risk. And I wouldn't say specifically suicidality, but greater mental health risk in the general population. Alcohol use was kind of 50-50. We thought alcohol was going to be another factor that could contribute to risk here. But alcohol use was didn't distinguish those that reported suicidal ideation. Marijuana use was just pretty high across everybody in this subsample of folks. And I deferred to those of you that do more substance abuse research. I would this might be the representation of the population in general, or maybe not the whole population, but population of people in their late 20s, early 30s in terms of marijuana use. And this was just use. It wasn't abuse or any kind of problematic use. And 54% were single. So a little bit higher than 50-50, but 54% remained single. And in our sample, the majority of folks who participated in this subgroup, by the time they completed this evaluation, were in a partnership of some sort. So most people were somehow connected in a partnership. So the issues from the field that I'll talk a little bit about, that we feel like are worth consideration as people do this kind of work, that we found that suicidal thoughts and behaviors were very, very inconsistently reported. And a lot of people who had reported a period of suicidal ideation, particularly suicidal ideation, and even sometimes suicide attempts, did not endorse that when asked about lifetime suicide ideation or suicide attempts in this 30-year follow-up. So there is a little bit of a literature to suggest that for adolescents, suicidal thoughts and behaviors could be transitory, response to a developmental challenge, which I think we as clinicians feel very much is the case. But I think what we found in this data set that was kind of interesting is that then they seem to be forgotten or minimized with maturation, that people are not necessarily, this was a survey, this wasn't an in-depth interview, so don't get me wrong, but people were not endorsing that they had made these reports before. And there is a literature, just in a small literature on this idea. We had a period of time where we talked about conduct disorder, that there was an adolescent limited period of conduct disorder, and that's come into controversy. But Thompson and Swart are talking about adolescent limited versus persistent suicidal thoughts and behaviors. And they had a large sample also, not as longitudinal as the sample that we had. They didn't follow them as long as we did. But they found that there was a group who had adolescent limited, didn't report suicidal thoughts and behaviors in young adulthood. They were seen once in adolescence and once in young adulthood. And those with limited, it was associated with decreases in report also of depression and of alcohol use. So kind of a period of difficulty in adolescence that seems to resolve as these young people move forward. And then those youth that were persistent in their reports of suicidal ideation, it was associated with ongoing risks, including limited social support, early alcohol use, and increases in negative life events. So again, not a surprising problem, but we may have, as we collect this data, we may have to question the data, because we're not necessarily, if you're doing longitudinal work, which is people are indicating the need for longitudinal work, but we have to be thinking carefully about what does it mean? What are people going to report over time? So as I said, reports of suicidal ideation and suicide attempts are highly variable across time. Individuals are not always reporting consistent histories. And our takeaway is that these observations may suggest a need for thinking about in a longitudinal context, how the timing of evaluations, um, and the kinds of questions that are asked in the evaluations. So our evaluations, just by nature of um, the amount of work that it takes to do a longitudinal study and the amount of support that it takes to maintain a longitudinal study, we, as you could see from the earlier slides, we saw these kids a number of times in middle and early high school. Then we saw them twice in high school. Then we didn't see them again. We weren't connecting with them again until young adult life, kind of late college or early work life. Not we had a sample that certainly were not all moving directly to college. And then we connected them with them again, not until late 30s. So to get really accurate data on something as, for a lot of people, perhaps transient, on and off, um, not pleasant in most cases, or not something that you would necessarily hold in your memory or want to hold in your memory. To get really accurate data, you would probably need to do more frequent assessments, and be very careful about consistency in wording of your assessments and in the time period you're asking about. Because we were asking people to both talk about a long time period and then a more immediate or shorter term time period. So we worry that our data is open to, it just raised some really interesting questions to us about how best to collect this data. We're very pleased to have gotten it at all and gotten some information to report, but we do think we all have to be thinking about what are people going to say down the road about their early suicidal ideation or the persistence of their suicidal ideation. And that, I think, is what I have for you guys today. I think the goal was to talk about 40 minutes, and maybe I talked a little bit less than that, but I'd be happy to take questions or comments or thoughts about next steps. We clearly haven't dug very deeply into the characteristics of these young adults who are reporting suicidal ideation. We had a few people who reported suicide attempts, not enough to really make any kind of a substantive comment.
So one of the things I'm thinking is this kind of so if I'm understanding, they're saying at a later point when you ask them about sort of lifetime, they're saying, "Oh no, that wasn't a thing," even though when you talked to them earlier, they said, "Yes, it was. Yes, I am suicidal or I have been suicidal," and then they're later not remembering or not reporting because that's been an issue in the field for a while that we have these school-based studies with really high suicide attempt rates that when we then, if you do an epidemiological study of adults, the rates are actually lower, which is theoretically impossible. Um, so one explanation that your data could speak to that I think probably most people's couldn't is the fact that that might be because they literally stop thinking about it. Like it's so interesting to think like what is happening? Is it that they really aren't thinking about suicide anymore? Like they just literally don't remember that this was ever a thing? Like that's just a developmental process of some kind, or they think now that what they thought then wasn't serious, maybe, or something. That what they think of suicidality now, at age 30 means something different than what they thought when they were 50. I just think that that's so interesting, and I don't think anybody has that data anywhere where you have the same kids across such a long period.
Yeah, I just want to be really clear. So what you're saying is exactly what we found, but I just want to be clear. We didn't ask them, they didn't have to negate prior report. They were just asking if if this had happened to them before. So if, they had to endorse that they had a history of suicidal ideation or suicide attempts. So yeah, they're like that was then and this is now. And that's uh, no longer kind of part of my history or my sense of myself, are what I remember about the ups and downs of my adolescent and really early, late teen um, situation.
Yeah, kind of on that point, I was thinking like it's interesting. It would be interesting to see how people weave suicidal ideation into their personal life narratives, because I feel like if somebody had this narrative of like, I had a rough time in high school, I overcame that, right? Like, and this has shaped who I am and whatnot, perhaps that they're more likely to remember that suicidal ideation down the road. But for somebody who maybe had a really rough time, but they didn't think of it as like shaping their identity or their narrative in any way, then that might kind of, they might forget about it, or it's not as prominent in their life, and so they won't report it in adulthood. I've been getting really interested in like scripts and narratives lately, and I would be curious to know if that might be impacting people's memories here.
I think it would be really great to have the narrative of what, because we see that even with the adults, that the parents of the kids that we see, like they will allude to having had a hard time when they were a certain age, but kind of minimizing it. And it would be good we haven't done any getting narratives from them either about what they remember, what they don't remember. And and it's almost, yeah, if they take it seriously still, if they think about this as something that's more um uh it was just drama, just high school drama or college drama, or was it real? Um, we deal a lot with parents who think it's manipulative and not real. So that's another feature that how people may think of it.
Julie Richards did some research, of people who reported they were not suicidal on the PHQ-9 and then within 90 days attempted suicide. And she sort of identified that crowd and found a qualitative sample and sort of asked them like, what do you make of this and why? And some people chose not to disclose it. Other people just, they literally weren't suicidal when they filled out that PHQ-9 and things changed in 90 days. But I feel like it'd be very interesting to talk to that subgroup of people who didn't and just get their own sort of qualitative take. I don't know if you had any realization of this, but you told us X at 15 and Y at 30. What do you make of that? I'd be really interested in um, what their experience was of doing that, finding a way to do that that sort of validates that this is their life experience and that we're not thinking that anybody's not giving us their genuine report, but that we actually really are interested in how what they make of that.
Yeah, we did not include our earliest data because I mean, that is where we could really get a lot of kind of inaccurate in a way reports, or very early or uninformed reports, at least from kids, not maybe from parents. But yeah, these kids were, I mean, this was 15 on, so by that then you would think that they would be reporting, they would know what they were reporting about, what they were endorsing, I would think. But maybe it was, I think it would be interesting. I hadn't thought about doing the qualitative piece, but I think we have a very committed sample of folks. I think we got everybody because we paid people, not a huge amount of money, but people were frequently willing to do our surveys because they got a little bit of pocket money to cover some expense they had.
Did you
It
collect
would be
information
interesting.
on technology use?
We did not collect information on technology use. Yeah.
It seems like this is a primo example of like the trans, like, or this sample is very in a time of flux and change, smartphones and because they're 30 now or they're a little bit older than 30 now.
No, we just collected this. I mean, they might be 31 now, 32, but
Okay, but
we
it's
just
yeah.
collected this. Yeah.
Okay.
This final way, we just collected that data. Yeah, survey. But we did not, it's a great question. We did not collect that kind of information. I would guess that the oldest of our cohort, but they stretch out over about 4 years, 3.5 years in age. So they're all pretty much the same cohort, age-wise. Yeah, it's a really interesting thing to kind of figure out what was going on for them and what's happening over time. Um, I think what we had anticipated is that we would get a declining, a kind of a trajectory in late adolescence, maybe a peak in early adult life during the stress of kind of what am I going to do with myself? How, what are my next steps? Big transition times, 22. Um, we were not expecting to get more people at 30 who were reporting ideation.
Something that I'm wondering about, just because a lot of my friends are kind of in the 30 to 40 range right now, and something we talk about often is how different our lives are. So we have some friends who have two kids, right, and some friends who are still single and dating, and so your social support network that you've formed in college or even earlier in life and whatnot, all of a sudden starts falling apart because people are now in different life stages despite being the same age. So something I'm wondering is that we see like these like school-based like institutional transitions from 15 through 22, right? Going from high school to college, college to the workforce and whatnot. And those are kind of those major life transitions where you may still be um, making new friends, right? Changing friend groups and whatnot. But I'm wondering about like at age 30, whether or not there's a dismantling of the social networks that you've already built. And so it's almost like these social networks that you already have that have been protective are now kind of coming apart, which is a little bit more devastating, perhaps, and makes you feel more lonely than having your old friends and now having to juggle your new group of friends and whatnot through these institutional transitions.
Yeah, super interesting point. And that's actually something we have the data we could look at because we have social support as a predictor, but we also, early on, but we also have it at 30 and we could look and see if they have a difference in their report of social support at the time of this evaluation from the rest of the sample.
Yeah,
Um,
and I think COVID also, like I know a lot of people who like lost a lot of friends during COVID because they were really just kind of friends because of proximity. They were working together in the workplace, right? Like they're seeing each other at clubs, and suddenly without COVID and without those in-person events kind of keeping them proximal to one another, suddenly you have to make a lot of effort to like talk to people you still cared about and make friends and whatnot. And so it's not as effort. And so I wonder if that transition also created some disruptions between the 22 and 30 age.
we could look at that. Yeah. These are great ideas. I do. We all will appreciate them because we've just kind of taken a peek at this data and are like, well, what does that mean? But we're not exactly sure what it means, and we don't. It's not a huge number, but we are interested in kind of figuring out who are these people and what kind of support would be most useful to them. Um, So some really great things to kind of follow up on.
So I'm not hearing another question. Did anybody have a last question before we um this is super helpful. This is an amazing data set. This is really amazing data set and while the suicidal folks are only a subset of it, I can imagine there's all kinds of interesting things that you've been learning about kids in general as they go um, through this kind of aging out through adolescence into adulthood. So I really appreciate you sharing this. I remember the early days of you collecting this original sample, and it really it's so interesting to see things come to a conclusion. And here these kids are 30 now.
30, it's unbelievable. But there, it's also, we were really convinced when we went into it that we were going to see these merging pathways between externalizing and internalizing young people, and really people stayed pretty true to their primary pathway over time, with depression and conduct disorder not crossing over as much as we thought it would. And that may actually be something that comes in this later part of life when you are um, kind of, clearly conduct. Both of those disorders can increase the negative life events you've been exposed to. But we haven't looked at that at this point with this sample because we were focusing on suicidality. I
Yeah.
guess the last question, I know we're almost at time. Any other thoughts for this family? We could look at other questions. You guys have given me great ideas. I'm going to look at, I think the social support and the chance of doing some narrative things could be very interesting. Um, I think the family it wants something to be revealed that is explanatory to them other than family support.
Well, I do think
Um,
that, it all depends on how much the patterns that you're finding relate to the patterns that happened with their child. And I think the ability to be able to see, the impact of alcohol on life events. I mean, I think these are the kind of things that we speculate are the case, but we don't have any actual evidence are the case. So, I think you are learning a lot, but it may be still a bit unsatisfying for
right.
them.
Yeah. And yeah, I think they feel good about adding to the literature, sorting some things out, and but it's painful for them for sure.
Yeah.
Um, so the bottom line is what we suggest that we need to do is build up social supports and get kids engaged as adolescents in things that will help them have strong enough social supports to hopefully stay to kind of counteract negative life events or keep them minimize those negative life events which are associated with substance use. So it's kind of the whole same whirl of
Mm.
positive engagement, productive engagement.
Yeah. And the
Um,
importance of protective factors and not just risk factors. I think
right,
has
right.
really been emerging and started being identified mostly in tribal populations, but I think we're really learning it's something that affects many, many people.
And I
So
think that the social support piece, just one final, it's really rebuilding it because that's a place where I think so many kids lost their. I mean, we are still seeing that with the adolescents that we work with, that the number of kids that are homeschooling or online schooling or doing all these things as opposed to being engaged with other kids is still really a big challenge.
yeah. So there are a few comments in the chat. So Macy, maybe you can hang on to those and send those along to Elizabeth. I will say Next month, I'll be presenting on the issues of data safety monitoring in trials with suicide research and how that differs from other data safety monitoring plans and data safety monitoring board oversight. And so we hope you'll come back and see us in the third week of March. Take care, everybody.